Hello, everyone. My name is Deborah Money, and it's my pleasure to welcome you to this webinar. I'd like to begin by acknowledging that we're hosting this webinar in Vancouver, British Columbia, which is on the traditional ancestral unceded territories of the Coast Salish people. Let me just introduce myself. I'm a professor in obstetrics and gynecology and a subspecialist in reproductive infectious diseases and the executive vice dean at the Faculty of Medicine here at the University of British Columbia. I've had the pleasure and the privilege of working with women living with HIV and providing reproductive health care to them, particularly pregnancy care, for 25 years, and I will be your moderator today. I've also had the privilege of practicing in a country with generally good access to reproductive health care in the context of a clinic, the Oak Tree Clinic, which provides women-centered care, and have seen the evolution from 25 to 30% transmission of HIV through vertical transmission and sadly very high mortality rates in women and their children to the current time where we can support women to have safe and healthy pregnancies with, in most cases, a less than 1% transmission rate. However, we have not solved all of the issues. We still have some individuals whose children end up with HIV. We have high rates of preterm birth and higher rates of perinatal complications, and we need to understand these better. In Canada, despite having data on over 5,000 mother-infant pairs to help inform our care, and myself personally caring for over 500 pregnant women living with HIV, we continue to struggle to ensure women are able to access good health care and be able to be in a point in their lives to take antiretroviral medications and ensure optimal pregnancy and newborn health. We've made enormous strides, but much work needs to be done to achieve the highest quality maternal and newborn health in all dimensions. On that note, it is my pleasure to welcome you to the Canadian webinar series on implementing the WHO guidelines on sexual and reproductive health and rights for women living with HIV. Today is the third webinar of the series where we will focus on reproductive health, rights, and justice. This webinar series is a collaboration between the World Health Organization's Department of Reproductive Health and Research, CHIWOS, which is the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, and the Canadian Positive Peoples Network, the Oak Tree Clinic at BC Women's Hospital, Women's Health in Women's Hands Community Health Centre, the Canadian Aboriginal AIDS Network, and the IBP Initiative, alongside many partners across Canada working on sexual and reproductive health and rights of women living with HIV. It is now my pleasure to ask Elder Valerie Nicholson to officially open our webinar with words of welcome and remembrance.
Kwe. Next. My name is Valerie, the one the eagles watch over, Nodi Wenda, which means wolf eyes. I am Mi'kmaq on my dad's side and Haida on my mother's side. I'm a mother of 4 boys, a grandmother of 3 grandsons, 1 granddaughter, and a grandson that'll be arriving on Mother Earth in approximately a month. We're opening this webinar from the ancestral, traditional, unceded territories of the Coast Salish peoples and all those around our Coast Salish Sea. I welcome all from around our Mother Earth with open arms, which shows our hearts are one, which is our tradition when we come together to raise our arms, which shows that we come in peace, openness, and that we do our work in a good way. Kwe, welcome. Next slide. There you go. I acknowledge all the voices of the positive women whose voices live on in this research, and to remember all those that have gone on before us and all those that are left behind. All my relations, we are all one. Please remember. Thank you.
Thank you very much, Elder Val. So next slide, please. Before getting started with the program, we have several objectives for today's webinar, which I believe were circulated and you can see on the screen. I won't go through these, but this is the background to our webinar. All of these objectives are important, but I do want to emphasize the final objective on action. The Across the 4 planned webinars in this series, we will collate the presentations, discussions, and priorities identified to draft a national action plan on sexual and reproductive health rights of women living with HIV in Canada. This webinar is an important step in that process. Next slide. These are today's speakers. We've put up photographs just so that you can see the individuals because we're on this webinar format. We're fortunate to learn from this diverse group of leaders in sexual and reproductive health, rights, and justice from across Canada. Next slide. So a brief overview of our agenda this morning. We will begin with Dr. Manjula Narasimhan, who will introduce and provide an overview of the WHO Consolidated Guideline. Krista Williams, who will provide a framing of our important discussion on reproductive rights, health, and justice. Brittany Cameron, who will present the realities and priorities of women living with HIV who are accessing reproductive care. Dr. Angela Kaida, who will provide a research overview. Dr. Mona Lutfi, who will present the recently updated pregnancy planning guidelines for women living with HIV, and Dr. Sarah Green, who will present a toolkit on supporting mothers in ways that work. Frédéric Chabot, who will present on access to sexual and reproductive health services in Canada. And we will then hopefully leave about 20 minutes for discussion and Q&A, and we'll close with some next steps. Finally, just some housekeeping items. When you're wanting to ask questions during the presentations, please submit any questions using the text feature of the application. Presenters will answer questions during the discussion session at the end of the webinar, and our team will collate the questions and ask them to the presenter on your behalf. If you're joining us by phone, please send any comments or questions by email to sawatt@sfu.ca. And if we do not manage to address all questions during the webinar, the organizing team will collate the questions and send responses to all webinar attendees after the webinar. Questions and answers will also be posted online with a recorded version of the webinar. Also, please type any technical difficulties into the text feature. The webinar will be recorded and posted on the IBP channel and the WHO SRHR YouTube channel, and links will be posted at the end of the webinar. And there are handouts that you can download for your own viewing and reference. If there are references and tools you would like to share, please send them to Sarah at the email referenced above. Next slide. So we are very grateful, of course, for all of the support received from the IBP initiative, the World Health Organization, and the Social Sciences and Humanities Research Council of Canada to permit us to host these webinars. Next slide. So on behalf of today's presenters, we note we do not have any conflicts of interest to declare. And on that note, we'd like to get started. So it's my great pleasure to introduce our first panelist, Dr. Manjula Narasimhan from the WHO. Manjula, please go ahead.
Dev, it seems Manjula is having problems with her connection.
Okay. Do you think we should go out of order and move on to Krista if she's ready?
Okay, sure.
So could we advance to Krista's slides? Krista, are you okay?
Can you hear me?
Are
Yes,
you
Manjula.
going next?
Hello?
Go ahead, Manjula. It seems your connection is back.
Great.
Ah, okay.
Thanks,
Hi.
man.
Sorry about that. Hi, everyone, and thank you so much. It's been a real pleasure to be part of this webinar series, and we're very excited about the outcome.
Hi, Ados and Deb. It's Mona here. Since I was on the guideline development group, maybe I can do the slides for Mangela.
That would be great, Mona, if you wouldn't mind, because I think Mangela is having some problems with her audio.
Okay, I'll do that.
Thank you.
Hello, everybody. My name is Dr. Mona Lutfi. I'm an infectious disease specialist that treats HIV and hepatitis C in Toronto, Canada. And I had the pleasure of being invited by the WHO to be one of the guideline development group members for these guidelines. The consolidated guideline on sexual and reproductive health and rights of women living with HIV, which were officially published last year in 2017. Next slide. We're really excited for this particular webinar since the main premise of these guidelines is about sexual and reproductive health and rights for women living with HIV. And there were some very important new recommendations in the consolidated guideline related to that. Here are a few of the new recommended recommendations. One is related to cesarean section, and the WHO recommends that elective cesarean section should not be routinely recommended to women living with HIV. This is a strong recommendation with low quality evidence. You might think that it makes sense in the context of Canada. Treaters like Deb and myself, who see many pregnant women living with HIV, if the viral load is suppressed, natural vaginal delivery is recommended. But throughout the world, care providers were still pushing elective cesarean section, and it's for that reason that this new recommendation is important at a global level. Another new recommendation is that the WHO recommends that safe abortion services should be the same for women living with HIV who want a voluntary abortion as for all women. This is a strong recommendation with very low quality evidence. And again, this is common sense in Canada, but not necessarily the same around the world. Another recommendation, the WHO suggests that women living with HIV who want a voluntary abortion can be offered a choice of medical or surgical abortion as for all women. There was a lot of debate about this recommendation. It was conditional, but when you have a conditional recommendation, it is still a recommendation with very low evidence. And even in the context of Canada, we had delays of arrival of medical abortion, which we finally have, but access is still a problem. And in many countries, abortion is not easily accessed, and these guidelines recommend access to voluntary abortion, not just for women living with HIV, but for also all women. Next slide, please. Thank you.
Thanks very much, Mona, for stepping in there. Hopefully Manjula's connection will improve and she can maybe add some comments nearly the end. It's now my opportunity to turn it over to Krista Williams from Native Youth Sexual Health to frame our discussion. Krista, would you like to go ahead?
Yeah, sure. Thanks so much, everybody, for joining today. And thanks to the organizers for inviting us to give what I think is a really important political and social context to talking about reproductive health, rights, and justice. The first image that you'll see there is by Erin Marie Consmo, some cardboard spray paint work, and it simply says reproductive rights are land rights. And so this is for us as Indigenous communities really important to recognize that bodily autonomy and the struggle for that is intimately connected to the lands and territories that we're on, and to really invite people to that's something everybody can consider. You can consider whose land you're organizing on, whose land you're doing this work on, and how that changes your relationship to the type of work that you're doing. Next slide. So first off, who are we as the Native Youth Sexual Health Network? We're a by and for Indigenous youth organization. We work throughout the US and Canada across issues of sexual and reproductive health, rights, and justice. We've been around for about 10 years. And I'm actually here today as a mentor, not as a youth leader. I've aged out since then, but we're also trying to make space for intergenerational networks and organizing in our communities. So what I'll be presenting and talking about today is kind of a coalition of a lot of knowledge from many different people, not just myself, who have taught us and shared with us about reproductive justice. Next slide. So it's important for us to recognize that this type of resistance has many different connections. It's not just a single issue. We can't just focus on one thing like sexual health or reproductive rights or anything like that. We really have to look at a kind of timeless understanding of how Indigenous people have understood the relationship to our bodies, how those things have been controlled, criminalized, coerced, etc. over time, and that is intimately connected to how it is that we now address current issues that our communities are facing. So we're talking about process of cultural reclamation and land reclamation. We're also talking about a restoration of things that were disrupted as a result of colonialism and other processes that interrupted a lot of what we traditionally and still do in terms of sovereignty over our bodies and our communities. And the image there, just talking about the scope of our medicines and what that can look like now, currently. Next slide. Okay, so what is reproductive justice? What I was asked to talk about. You know, you could Google and there's papers and you know, talks and people who have been at the heart of this movement for over 25 years, specifically resisting population control, eugenics policies, all of these things that actually can still sometimes infuse and inform, especially healthcare and the way that we do work related to HIV, related to pregnant women, things like the history of sterilization, which is not even a history, it still happens to lots of different populations. The present realities around long-term acting reversible contraceptives, for example, how that research happens, how that dissemination happens, and how those substances end up in people's bodies. All of those things are still informed and related to this really intense history that we have around population control and eugenics. So reproductive justice was formed by women of color in the US who were really sick of the pro-choice movement not being intersectional, not talking about the other justice issues that they had in their lives that were really informing and controlling whether or not they even had reproductive options or choice to begin with, and kind of only looking at abortion rights as the way forward in terms of autonomy over our bodies. So it really tries to encompass theories, practice, and strategies to really unite across social movements and not just be this like single issue and now we have another thing to think about. So technically what it speaks to is the right to have children, not to have children, and to parent the children we have in safe and healthy environments. And so as you can see, that's a lot of different things that could go across a lot of different places that people organize from. Also knowing that the conditions under the societal conditions under which people make reproductive choices are informed by a broader analysis of structures, of systems, and how those inform different people's social realities, and that we actually need to take that all into consideration before we can even talk about choice or health for the focus of this webinar. So looking at those constraints on power, and then how can we organize around them to then advocate for more control over our bodies more broadly, instead of this narrow focus on legal access to individual choice, which was and still is, can be the focus of a lot of mainstream organizations. Next slide. So the next slide, you'll see just a little bit about how different issues and different social movements connect to reproductive justice, and what does that look like in terms of all the different things that people organize on. So we're here specifically talking about women living with HIV and pregnancy, but we know that that's connected to so many other systems and so many different ways of thinking of those things. Next slide. So this quote, while a bit long, is really important. This is from one of our youth leaders in the East Coast. And when we were sharing and learning about reproductive justice not that long ago, you know, we started to realize that this was just another word for sovereignty. This was another word for gender equality practices that a lot of our communities and nations already had in place. That were interrupted by colonialism and that were deliberately displaced as part of political movements to get land and power and all of these things. So it really focuses on this disrespect and this erasure of Indigenous understandings of how it is that we organize our communities in ways that make sense for everybody. And so at the last line, which is bolded, which is really what we wanted to talk, what I would like people to focus on for today, is that our forms, which when she's saying our, it's Indigenous forms of reproductive justice, were made illegal on purpose, but that's never mentioned anywhere. So when we look at the fight for abortion rights, for example, all of the different, you know, kind of legal struggles, et cetera, that people are focusing on, we're not looking at why do those laws exist in the first place? What happened to make that illegal? And a lot of when you look back at some of those laws historically, they're tied to the genocide of our communities, they're tied to land theft, they're tied to all of these things. And so if we don't pay attention to that, if we don't learn from that, then our solutions are also not going to address that and are only going to be kind of surface level and aren't going to get to the root of why we're in this situation in the first place. Next slide. So specific to HIV and what we're talking about today, we didn't come up with this is from RISE, really fantastic youth-led movement as well. Talks about kind of the intersection of all of the different issues, you know, that Indigenous communities don't have the luxury of being single issue. We can't just focus on one thing. We have a lot of simultaneous realities that inform each other and that need to be considered as part of a whole. So really talking about stigma, talking about the influence of colonialism and that's ongoing, how things like poverty and sex education really inform how people understand the world around them, how they understand their bodies, and because we have so many other things also going on, but also that we have a lot of strength and we have a lot of rights, and we actually have a really long history of survival, of resistance, and of getting by when things are tough. So it would make sense that we would actually look to Indigenous communities for leadership, also because we're the most impacted by a lot of these things, but we also have a lot of skills to offer around how to resist and how to rebuild in times of crisis. Next slide. So if you want more information, because this is a very, you know, kind of quick overview, and I'm sure I've missed lots of things, and maybe you have things that you understand to be true in terms of reproductive justice. So I want to invite you to a Twitter chat that happened not that long, a few years ago, that would give a little bit of history, and it was lots of different organizations and movements kind of really talking about how they understand the history of reproductive justice. So the hashtags are there, although those hashtags are pretty generic. You might see other things, but you definitely want to make sure it's the specific organizations like Sister Song that are listed here to look that up. And of course, there's lots of other places that you can go to for that, but definitely Sister Song as far as the historical perspective as well, if you want more details about that. Next slide. All right, so there's our contact information. Thanks, Anushik, so much, everybody, for listening. And I really hope that this reproductive justice continues to inform the ways in which we move forward on all of this. So, Anushik.
Krista, thank you so much for that. That was wonderful. It's now my honor to introduce Brittany Cameron from PIRN Community-Based HIV STBBI Programs. Brittany, please go ahead. Ados, we're not hearing Brittany. Is she
today from the traditional territory of the Anishinaabe Mississauga, adjacent to the Haudenosaunee territory and in the territory covered by the Williams Treaty. Can you hear me?
Brittany, can you hear us?
Hello?
Go ahead, Brittany.
I
Go
can
ahead.
hear you. Can you hear me? Okay, thank you. Sorry, I just wanted to acknowledge that I'm speaking to you today from the traditional territory of the Anishinaabe Mississauga, adjacent. Hello, can you hear me? Hello.
Hi, Brittany. We
Can you
are
hear me
hearing
now?
you. Go ahead.
Hello.
Brittany, we are hearing.
Hello. Okay. Okay, so acknowledgement of the traditional territory in which I work, live, and play, the Anishinaabe Mississauga, adjacent to the Haudenosaunee territory and in the territory covered by the Williams Treaty. Before it became Peterborough, this area was called Nogojiwanong. Next slide, please. So growing up was not easy. My parents were both addicts and I eventually ended up on the streets. During this time, I engaged in sex work and I became addicted to crack. I had regular involvement with the criminal justice system, and ultimately, after my youth incarceration, I ended up in Montreal, back on the streets and continuing to be engaged in sex work. In September of 2005, I got on a public health bus and the nurse suggested I was pregnant.
Hi, Ados and Brittany. We seem to have lost audio again. It's Deborah here.
Deborah, I'm so sorry, but I think the connection that Brittany has.
I was standing on the phone that I was HIV.
Brittany's connection comes in and out, so I'm not sure it's going to improve. It has been doing that since the beginning of the webinar.
Hi, Brittany. Can you hear us? Because we're having trouble hearing you. Oh, dear. I think very unfortunately, we may have to move ahead to the next speaker. And Brittany, if you can hear me, then and your connection gets better, we could cycle back to your presentation if that's okay. I'm really sorry about that. So just in the interest of keeping the flow going, what I'm going to ask is that we skip ahead to Dr. Angela Kaida, and then I hope we can come back to Brittany later in the webinar. So Angela, please go ahead.
Thank you, Dr. Money. And thank you, everybody. Brittany, truly, I hope we'll be able to get you back because that's your story really does set the stage for what we're talking about today. But I will go through this presentation and really hope that we can bring Brittany back near the end. Next slide, please. Let me begin by acknowledging and thanking women living with HIV, our partners, our communities, our funders, and the many individuals and organizations who support CHIWOS and make this research possible. Next slide, please. We also honor and remember each of the 52 women living with HIV who participated in CHIWOS and who have since passed away. And we thank them for sharing their stories with us. Next slide, please. By way of a brief introduction, the health and survival outcomes for people living with HIV have improved dramatically since the introduction of combination antiretroviral therapy. HIV treatment with sustained viral suppression is also enabling safer reproductive options for women living with HIV, including better maternal health, improved fertility, dramatic reductions in perinatal HIV transmission, and recent findings showing that sustained viral suppression effectively eliminates risk of HIV transmission to HIV-negative partners during condom use. These improvements have transformed the reproductive health landscape for women living with and affected by HIV. Next slide, please. And of course, motherhood is important for many women living with HIV in Canada. And an estimated 26 to 58% of women report fertility intention or pregnancy desires. Proportions of approaching those of the general population of women in Canada. A majority of women living with HIV, however, do not want to have children, either now or ever, and require access to effective contraceptive and safe abortion services. Next slide, please. So to inform the design and delivery of women-centered, integrated, and rights-based HIV and reproductive health programming for women living with HIV in Canada, we use data from the CHIVO study to assess the following: fertility intentions, discussions of reproductive goals with HIV care providers, current contraceptive use, incidence of pregnancy after an HIV diagnosis, pregnancy outcome, and whether or not women have a healthcare provider with whom she feels comfortable discussing her reproductive goals. Next slide, please. Briefly, in terms of methods, we use survey data from the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, or CHIVOS, which is the largest community-based cohort study of women living with HIV, trans-inclusive, in Canada. We enrolled 1,422 women living with HIV from 3 Canadian provinces, British Columbia, Ontario, and Quebec, with 18-month follow-up visits. Grounded in principles of critical feminist theory, anti-oppression, and community-based research, CHIVOS involves women living with HIV and allied clinicians, researchers, and community members as core partners throughout all stages of our research. Next slide. This table provides a quick look at the baseline characteristics of women who participate in CHIVOS. And you can see that the median age is 43 years, and then at the ethnic diversity of women mirrors the distribution of HIV among women in Canada. You can also see that in our study, the vast majority of women have received HIV medical care in the last year, so 94%, with 83% currently on treatment and 80% reporting an undetectable viral load. Next slide, please. So moving on to some of our results. You can see in this figure that 1 in 4 cisgender women of reproductive age reported intending to become pregnant at some point in the future. But we also see that another 19% of women reported being unsure or ambivalent about her future pregnancy intentions. And this is certainly consistent with what we know about pregnancy decision-making, which for many women is complex, shifting, and highly context-dependent. So our data show that nearly half of women living with HIV intend or are unsure about their intentions about a future pregnancy. And these statistics set the stage for us regarding the need for comprehensive reproductive support across HIV care and across the life course. Next slide, please. Here, we asked women if, since knowing her HIV status, had she ever discussed her reproductive goals with a healthcare provider? And keeping in mind that this cohort is highly engaged in HIV medical care, we found that nearly half of women reported having never discussed their reproductive goals with a provider. And here we're able to distinguish those women who've never discussed their goals because they felt it might not be applicable to them. For instance, if she'd undergone a tubal ligation before her HIV diagnosis, from women who do have goals but have never discussed these goals with a provider. Next slide, please. Now, with respect to contraception, WHO guidelines advise that women living with HIV may safely use the full range of hormonal contraceptive options, with some few notes of caution. There's evidence of drug interactions between oral contraceptive pills and some ART regimens, which may increase side effects and or contraceptive efficacy. And in addition, for some women with advanced HIV disease, caution is advised for the use of IUDs. Next slide, please. So when we investigated use of contraception among sexually active women of reproductive age, we found that 73% reported use of an effective method in the 6 months prior to interview. This high prevalence of contraceptive use relative to the general population of women in Canada was driven primarily by use of male condoms and a high prevalence of tubal ligation. You can see here at 19%. But use of hormonal contraception was modest. Only 9% used the injectable, 6% the pill, and fewer than 2% had used emergency contraception, contraceptive patch, the female condom, the ring, or the implant. 6% of women reported using the hormonal IUD and 4% copper IUD. Next slide, please. And when contraceptive methods were grouped into mutually exclusive categories and included a measure of dual protection, which the WHO defines as use of a condom and another effective method of contraception, we found that 27% of women were not using any effective method, 27% used the male condom only, and 13% relied only on permanent methods. And use of female-controlled, reversible contraceptive methods was really limited. 8% used any hormonal method and 6% IUDs. We also explored an expanded definition of dual protection here, and which included use of either ART-driven viral suppression or condom use for HIV prevention with another effective contraceptive method for pregnancy prevention. And when we applied this expanded definition, the prevalence of dual protection increased to 40%, highlighting really quite a high prevalence of HIV prevention practices relative to contraceptive practices. Next slide, please. Switching gears now to pregnancy incidents. Of women enrolled in CHIWOS, we report that 24% had at least one pregnancy after an HIV diagnosis, but that 61% of these pregnancies were reported by women as being unintended. Next slide, please. And when we looked at using a retrospective lifetime history of pregnancy, we found that a higher incidence of pregnancy after HIV diagnosis in more recent years compared to earlier years of treatment in the HIV epidemic, and evidence of increasing pregnancy incidence over time. Next slide, please. And related to that increasing pregnancy incidence over time, we observed a higher incidence of unintended versus intended pregnancy. Next slide. You can see in this table, over the follow-up period, the incidence rate of pregnancies of unintended pregnancies was 1.5 times higher than that of intended pregnancy, again suggesting an unmet need for comprehensive contraceptive care for women living with HIV in Canada. Next slide. And related to this, with respect to pregnancy outcomes assessed for all pregnancies after an HIV diagnosis, we found that 18.7% of these pregnancies resulted in a miscarriage or stillbirth, 20.5% were terminated, and 57.3% resulted in a single or multiple live birth. At the time of interview, 3.5% of women in our study were still pregnant and were unable to report pregnancy outcomes. Next slide, please. And finally, we asked women and found that 42% do not currently have a healthcare provider with whom she feels comfortable talking to about her reproductive goals. And these data highlight a contemporary gap in comprehensive sexual and reproductive health care for women living with HIV. Next slide, please. A few final words. The power to decide if, when, and how to become pregnant with the information, means, and support to do so is central to the reproductive rights of all women, including women living with HIV. And CHIWO's findings demonstrate that more women are becoming pregnant in the ART era compared to ever before, but that a large proportion of these pregnancies are unintended. So we need to say that women must be supported if they do want to become pregnant. They must also be supported if they don't want to become pregnant. And women who are unsure of or ambivalent about pregnancy need support too. Next slide. And here I'd just like to conclude that HIV care delivery models, such as women-centered HIV care, and the equitable social environments that attend to reproductive justice may be best able to provide this support for women by centering reproductive rights and prioritizing discussions of women's sexual and reproductive desires and needs across the life course. Next slide. I just wanted to provide our list of key references for this presentation. And finally, next slide. Thank you so much for listening. And if you have any questions or would like more information about CHIWOS, please contact any one of our coordinators listed here. Thank you very much.
Angela, thank you very much for that summary and sharing some of the CHIWOS data. So I think what we're going to try to do is go back to Brittany, who we had some technical difficulties with, and hope that she's able to present to us now. Brittany, if you can hear me and you're connected, please go ahead.
Hi, thank you so much, and apologies for those difficulties. I wanted to acknowledge that I did the traditional territory acknowledgement, and I'm just going to get right into my story. So next slide, please. So for me, growing up was not easy. My parents were both addicts, and I eventually ended up on the streets. During this time, I engaged in sex work and became addicted to crack. I had regular involvement with
We're
the
not able
criminal.
to hear you right now.
Can you hear me?
Sure.
Hello? Hello?
Yeah, we hear you perfectly.
Perfectly.
Whitney.
Okay, thank you. So I was just talking about, growing up.
Oh, they can hear.
Ultimately, after my youth incarceration, I had ended up in Montreal on the streets, engaging in sex work. In September of 2005, I got on a public health bus, and the nurse suggested I was pregnant. In fact, I was. I went to a local clinic, requested an HIV test. Sadly, I ended back up in incarceration. Once I was released, I got on a bus to Peterborough. I didn't look back. I knew I had to be clean and sober to keep my child out of the care of Children's Aid. Next slide, please. What I didn't know when I moved back to Ontario was that my Quebec healthcare would be denied. I was 5 months pregnant, and so when I was finally able to access care and coverage, I was able to have an appointment with a local doctor. I was standing in the bathroom of a rooming house when the doctor told me over the phone that I was HIV positive. She went on to tell me that she had no previous experience in terms of providing care for an HIV positive woman and suggested that Mount Sinai would be my best option. I was connected into the positive care clinic. I started ARVs all within 3 days of my diagnosis. I was 20 years old, 36 weeks pregnant, and HIV positive. Next slide, please. I connected to care at Mount Sinai Hospital, and my birth plan instantly shifted. Unplanned section at 38 weeks, only 2 short weeks after my diagnosis. No breastfeeding, IV lines, and an epidural that had lasting effects. Not an ideal birth by any means. However, my beautiful daughter Alexis was born. She was given oral medications for 6 weeks and was followed by Sick Kids Hospital for 18 months. Next slide, please. I love being a new mom. I happened to have Children's Aid involvement for about 6 months after Alexis was born based on my past history and my HIV status. Sorry. It was hard because I was on social welfare trying to make ends meet. In 2007, I decided to write my grade 12. I passed that. In 2009, I met my current partner, and I disclosed my HIV status before our first date. Next slide, please. In late 2009, I became pregnant with my second baby by way of traditional conception methods. I started medications at 12 weeks pregnant. I was educated on PMTCT and planned to have as natural childbirth as possible. This time around, I had a choice in where I could have my baby, and so I opted to deliver locally with an OBGYN that was willing to learn. Aaliyah was born vaginally in August of 2010. She had oral medications for 6 weeks, was followed by the Positive Care Clinic for 18 months, and is HIV negative. Next slide, please. In late 2010, just 2 months after Aaliyah was born, I became pregnant with my third baby by way of traditional methods. I started medications again at 12 weeks pregnant. I was able to continue to work with the same OBGYN as my last pregnancy, and my girls were actually a really big thing in our local hospital in terms of the PMTCT protocols. Amaya was born vaginally in July of 2011. She had oral medications for 6 weeks, was followed by the Positive Care Clinic for 18 months, and is HIV negative. Next slide, please. So, acknowledgement, I'm in a serodiscordant relationship. I've been with my partner for 9 years. He remains HIV negative. Earlier on, we struggled with his family and the challenges of HIV disclosure. And something interesting was we both kind of learned of the Swiss study in early 2009. And after the babies were born, I had opted to remain on treatment to help protect him. And I often say that we have been living U equals U before there was a hashtag. Next slide, please. I just wanted to quickly highlight some of what I've been doing 12 years after diagnosis. About 2 years into my diagnosis, I made a commitment to becoming involved and becoming a voice for positive women, especially mothers, because we often feel left out and isolated. By engaging in some of the processes, I've been able to build a community and give others, especially young women, hope, and that matters to me. Next slide, please. So just wanting to highlight some of the key issues that I'm seeing in our communities and amongst women living with HIV. So breastfeeding, HIV transmission, and HIV criminalization in the context of mothering. We know many HIV positive women want to breastfeed their babies, and we must continue to have conversations and research in this area so that we can actually make informed choices. For me, telling an HIV positive woman they cannot breastfeed when we know others are is simply not good enough. We know breastfeeding is cultural, and we need to be more aware of the harm it can potentially cause on mom when she cannot breastfeed. Personally, I had lots of guilt over this for a really long time. I definitely think there should be some more focus on how to better support serostatus couples. My partner worried about my daughters potentially being positive, and there was really no support for him. And finally, we need more women-centered research. All too often, we are underrepresented in the clinical trials and research. Women experience HIV differently than men. We must acknowledge that and make much more efforts to have equity in this research. Next slide, please. So yeah, thank you so much for allowing me a few minutes of your time to share my story, some of my concerns, and please feel free to connect with me. Thank you.
Brittany, thank you so much. And I'm so glad we were able to finally have your presentation today. That was wonderful. So we are now going to move ahead to Dr. Mona Lutfi's planned presentation. So Mona, please go ahead.
Okay, great. Can you hear me?
Yes, we can. Thanks, Mona.
Okay, great. Thank you so much, Deb. It's nice to hear your voice, Deb. It's been a while, and it's always a pleasure working with you. It's kind of ironic that we're having technical difficulties as this topic is so important to so many of us on the call, but we're getting through it. And Brittany, hearing your story was so important. So thank you for that. Reproductive health really is a continuum. So before pregnancy, during pregnancy, and afterwards. And other speakers have spoken about time during pregnancy, and I'm going to be concentrating on the preconception phase and pregnancy planning. Next slide. I will start by thanking many groups of people that are listed on this slide here, but I will specifically mention a thank you to our funders, the Canadian Institutes of Health Research. Next slide. Due to limited time to present, I've compressed the Canadian history of HIV and pregnancy planning into this one slide. This topic, as Brittany mentioned, was raised as a crucial issue by the HIV community in the early 2000s, when patients with HIV were being discouraged to get pregnant and were in fact also being refused to be seen by fertility clinics in Canada. So we launched the Canadian HIV Fertility Program in about 2007. And you can see this diagram here. What we did is we followed a knowledge translation framework. You can see on the left side of the diagram, we carried out studies and published work to determine the need for pregnancy planning and fertility services in the context of HIV. And on the right side at the top, you can see we also carried out studies to determine what services were available, and we realized that there was a very big gap. So that we put together a team of over 70 stakeholders and experts from across the country in different areas, and one of our activities was developing and publishing the first Canadian HIV pregnancy planning guidelines, which were published in 2012, and here they are on the right. Next slide, please. Since 2012, there have been many major clinical and scientific advances that impact fertility and pregnancy planning and HIV. So we applied for a grant to the Canadian Institutes of Health Research and were successful. And we started working in 2016 and 2017 to update these guidelines. And on January 1st of this year, 2018, the updated Canadian HIV pregnancy planning guidelines were published in the Journal of Obstetrics and Gynecology of Canada. The full guidelines are actually not open access, but if you email me directly, I am allowed to email them to you. And there's information of my email address. Next slide. Here are our methods for developing and updating the guidelines. The key points are that we use the AGREE method for developing guidelines. I know many groups use the GRADE method, which would be the preferred method, and next time we probably will use GRADE. And we use the Canadian Task Force on Preventive Healthcare for the grading. Next slide. Okay, so what's new and what's old in the 2018 guidelines? The guidelines have 8 sections, as you can read there. The first 7 sections are the same as in the 2012 guidelines. However, the 8th section is a new one on HIV infection control in fertility clinics. There are 36 recommendations, and if you get the full guidelines, the guidelines start with a very clear summary of all 36 recommendations. As in the old guidelines, we followed community-based and evidence-based frameworks. However, one framework that we added to the 2018 guidelines is the use of a human rights framework. So Krista and Manjula, you'll be happy with that. So we adopted the WHO's human rights premise that all couples and individuals have the right to decide freely and responsibly the number and spacing of their children and to have access to the information, education, and means to do so. And that includes people living with HIV. Next slide. I'm going to walk you through the 8 sections with the highlights. There's a lot of detail in the full guidelines, so I'm just going to summarize what I consider to be the important highlights. So section 1, ensuring a healthy pregnancy, child, and family. One of the recommendations is that reproductive health counseling, including contraception and pregnancy planning, should be offered to all people with HIV of reproductive age soon after HIV diagnosis and on an ongoing basis. Also, folic acid should be taken 3 months prior to becoming pregnant and for at least the first 3 months of pregnancy. Section 2 is about psychosocial issues and mental health, and there's a lot new in this section, so I recommend reading the full guidelines. And here are 2 of the important recommendations. Counseling should include a discussion of the potential risk for both horizontal and perinatal HIV transmission, including perinatal transmission via breastfeeding, and how transmission or risk of transmission might affect the mental health of one or both parents and other family members. The guidelines also emphasizes on encouraging non-stigmatizing discussion of substance use. The next section, number 3, is about legal and ethical issues. There's also lots new in this section. And one of the recommendations is that all people with HIV should be counseled on the possible ethical and legal aspects of pregnancy planning. Next slide. For section 4, which is on combination antiretroviral therapy and other drugs in pregnancy planning, the main changes relate to the fact that in all guidelines around the world, all people living with HIV are recommended to be on combination antiretroviral therapy as soon as possible. Also, the guidelines recommend timing of insemination in relation to starting combination antiretroviral therapy, which talks about PrEP, hepatitis C treatment, and I'll talk a bit more about those items. For section number 5, options for reducing risk of horizontal transmission during conception, couples and individuals should be counseled thoroughly about all horizontal HIV transmission risk reduction methods before attempting conception and supported to make an informed choice about which of the many options for conception method is most appropriate and accessible to them. Section 6 is the same as the 2012 guidelines and is broken down into scenario-based recommendations for the prevention of horizontal HIV transmission. And they are intended to guide healthcare providers through the specific preconception options recommended for each scenario. I'll go through that in more detail. Next slide. Related to this section, here are 2 new recommendations. All people with HIV who are planning to conceive should already be taking or imminently started on combination antiretroviral therapy, both for their own health and to prevent horizontal HIV transmission during the preconception period. They should be counseled on maintaining a high level of antiretroviral drug adherence to maintain a suppressed viral load. This is also a new recommendation. Condomless sex or sperm washing should be avoided as the conception method until the partner with HIV has been on combination antiretroviral therapy for at least 3 months with at least 2 viral load measurements below the level of detection at least 1 month apart. Preferably the partner with HIV should have been on combination antiretroviral therapy with a suppressed viral load for 6 months. When rapid viral load suppression is achieved through the use of newer antiretroviral agents, 2 undetectable viral load measurements at least 1 month apart should still be achieved before initiating condomless sex or sperm washing. If people want during the question period to ask why we worded this recommendation like this, I'd be happy to answer that. Next slide, please. In terms of pre-exposure prophylaxis, the data on PrEP should be discussed with all patients during preconception if individuals trying to conceive are in a serodiscordant couple relationship. HIV PrEP is not routinely recommended in the context of HIV and preconception in Canada. In this situation in which adherence and viral suppression in the infected partner cannot be confirmed, but conception attempts are still intended by the serodiscordant couple, pre-exposure prophylaxis should be recommended to the HIV negative partner. And this recommendation is based on the HPTN 052 and partner studies and 2 cost effectiveness analyses, which we have referenced at the end. Next slide. Here are the different clinical scenarios that we have written out in the guidelines, as you can see there. And what we recommend is that all conception options be discussed with all the scenarios, whether it's a couple where the woman is living with HIV and the man is HIV negative, or the scenario where it's a single woman living with HIV, and so on. We recommend reviewing the pros and cons of each option. And it's important to know that more than one option is often acceptable and recommended per scenario, and the chosen strategy is based on the patient's preference. This is really about counseling, giving the information, and an individual or couple being able to make an informed shared care decision. Some options may not always be the most practical based on availability of services. For example, if someone lives in a remote area, or cost or cultural beliefs, personal risk evaluation, or clinical circumstances. In these cases, physicians and other healthcare providers should provide non-judgmental support of the decision of the patients involved. Next slide. Okay, here are the different insemination and conception options for reducing risk of horizontal transmission. The first 2 relate to using condomless sex with the partner living with HIV being on combination antiretroviral therapy with a fully suppressed viral load. The second one has the condomless sex being done with timed ovulation, meaning at the time of peak fertility. And that one's highlighted there because in the new 2018 guidelines, this is predominantly the main recommendation of method of conception in most of the scenarios. The above 2 could be used with PrEP to the HIV negative partner. However, as discussed, if the HIV positive partner is on antiretroviral therapy with a fully suppressed viral load for an extended period of time, PrEP is not recommended in Canada and also not recommended in other countries such as the UK and Switzerland. Home insemination can be used with a syringe, sperm washing in a fertility clinic followed by IUI, in vitro fertilization, or intracytoplasmic sperm insemination. Individual or couple might consider an egg donation or a sperm donation with a gestational carrier, and also adoption is always a possibility. Next slide. Here are the last two sections, section 7 on infertility investigations and treatment. And in the guidelines, we recommend that people with HIV should be counseled about fertility issues that also occur in the general population, including genetic disorders and advanced maternal age, and offered infertility investigations and treatment if required, just like the general population in Canada. Section 8 is a new one and important to fertility clinics and relates to HIV infection control in the fertility clinics. Fertility laboratories should follow the Canadian Standard Association guidelines for infection control when handling HIV positive material, and use additional procedures available for the processing of HIV positive sperm to ensure the preparation of a virus-free sample. And there are some more detailed recommendations which are specific to fertility clinics. Next slide. In terms of our next steps, we plan to disseminate the guidelines across Canada, assist in their implementation, while also assessing the potential barriers such as stigma, access, ethno-cultural differences, and then we plan to assess the uptake of the guidelines with monitoring and evaluation. Next slide. Here are my references. Next slide. And I'd like to thank you for your attention.
Thanks very much, Mona, for that summary of the guidelines. I'm going to move straight ahead to introducing Dr. Sarah Green from McMaster University. Sarah, please go ahead.
Thank you. Can you hear me? Just want to make sure.
I certainly can.
Great. So I just first want to say thank you for inviting me to this amazing panel, and to also thank the Huron-Wendat Nation, Métis Nation of Ontario, Mississauga of the New Credit, Mississaugas of Scugog Island, First Nation, and Six Nations of the Grand River. So this I'm going to be talking to you about the Supporting in Mothers in Ways That Work toolkit. It was a toolkit that emerged from a 3-year study with a huge number of people, including Mona, who you just heard, and many people who've been on the call today, and in particular, many mothers living with HIV. And what we really wanted to know was what their experiences were as they went through the health and social care system during pregnancy, birth, and their first year of motherhood. And the data collection and all the methods are here, so I won't go through that in the interest of time. But I did want to say that for us, it was incredibly important that as we were doing the research, and when the research data collection and analysis was coming to an end, that we developed something that could be used by mothers living with HIV and anybody who may be working or supporting mothers living with HIV in clinical settings, social service settings, in places like shelters, for example, and wanted to develop something that was a learning opportunity, something that was grounded in a social justice approach to supporting mothers in ways that work, and that really understood the value of not just reproductive justice, but maternal justice as well. We were also very fortunate during the creation of the toolkit to also have been doing some other work, not just in Ontario, where most of this research was done, but in BC, that was supported by Elder Val Nicholson, that's on the call today, and other mothers living with HIV in Regina and Saskatchewan and Thunder Bay. Much of the work that they did and supported our work with has been integrated into this toolkit. And so it really is a joint effort that has the voices of mothers living with HIV from across the country, as well as people who work on the front lines and researchers as well. And so, as many folks have already talked about today, we really wanted to ensure that people who had little information in the work that they did, and if they were to, in their practice, be working with a mother or a pregnant woman living with HIV, that they would have a guide or a toolkit that would support them in appropriately and effectively and sensitively meeting the needs of women living with HIV. And so we wanted to give information about our approach, about the successes and shifts in HIV and pregnancy and motherhood, and the importance of listening to women's stories and making decisions around their care. So next slide, please. And so the purpose is really to increase health and social care providers' awareness and understanding of the needs and experiences of mothers living with HIV during the whole perinatal and postpartum period, but also as a toolkit that mothers living with HIV could also take and use themselves for their own knowledge, and to perhaps bring to a care provider if they felt that they needed to advocate on behalf of themselves. And that's exactly how it has been used. And so we show you what the target audience is for the toolkit, but it also is for mothers themselves, and we know that mothers have been using them. I would particularly like to give a shout out to Molly Bannerman, who works with the Y Initiative in Ontario, who has really supported this work through helping us access funding, and who has also helped to translate it into French. But she also provided us with an opportunity to take the toolkit and do training with Y workers across Ontario, whose job it is to actually go into settings like shelters, community health centers, child welfare agencies, people who don't actually think or know that they're working with mothers living with HIV, to go in there and sort of champion the toolkit and do training with people who have less knowledge. So this isn't just something to sit on a shelf, but that can be consistently mobilized in communities. And the training includes a number of sections. Again, these were sections that were determined through the data that we got through the mothering study and through other work that we've done, where women have explicitly said that they feel that the people that have been providing them with health and social care support need to know. And that includes what works and what needs to change. And so in each section, we've actually included data, but also the actual narratives of the mothers themselves. So we can go to the next slide. As Brittany was saying earlier, a really critical issue that emerged was around related to breastfeeding, why women aren't breastfeeding, or their experiences of not breastfeeding. And actually, since the writing of this, putting together this toolkit, the conversations have grown and developed in really important ways. And we really just sort of hit the tip of the iceberg here in this toolkit. And again, we offer folks some key practice implications of ways that they can actually move forward in their work. We also talk about, as Brittany was said earlier, mothers' experiences of criminalization of HIV non-disclosure and how this has impacted their experiences as mothers in particular, both in breastfeeding and also through health and child welfare practices. And just 2 weeks ago, I received more information about a recent case where a woman is in the process of losing her children to care. And her HIV status was actually highlighted as one of the areas of neglect that she was engaging in, just by virtue of being positive herself and inaccurately engaging in practices that could transmit HIV. And that, of course, takes us to the next section, which is around experiences of stigma and discrimination, and really providing a little bit of education, again, for healthcare and social care providers that are not situated in the HIV realm, to start thinking critically about who they're working with, and not to make assumptions that they're not working with people living with HIV, that women do not necessarily disclose, but would welcome an opportunity to be in environments where, if they wanted to, they would feel that they could, and that they wouldn't have to worry about stigma and discrimination if somehow their HIV status was disclosed. And in the final section, we have a section called Taking Action and it really focuses on, again, for health and social care providers in all areas of care to think about what they can do both as individuals in their practices, as collectives in their own agencies and organizations, and what they can do to support a system to be more supportive of mothers living with HIV. We can go to the next slide. And this is just a little bit of information about how you can access the Supporting Mothers in Ways That Work toolkit. It is available online. You can download it as a PDF. We have very few copies left. We keep ordering more and more and more, but we can't seem to keep enough on. So you can try and ask Allison, and she will also help you to figure out how you can get a French version if you want. We are actually now in the process, with the support of many women Indigenous women across the country, now developing a Supporting Mothers in Ways That Work that is specific to Indigenous mothers living with HIV. It's a community-based research process where we are collaborating with mothers and frontline workers across the country as we develop this work. Consultations are done. We're now in the process of starting to analyze and look at the consultation suggestions for the toolkit, so stay tuned. And that's it. Thank you very much.
Sarah, thank you so much. So now it's my pleasure to introduce, last but not least, our final speaker, Frédérique Chabot from Action Canada. Frédérique, please go ahead.
Hi, thank you for having me today. Abortion care has been mentioned several times during this conversation, and so I'm really excited to be able to offer more information on what access looks like in Canada at this time. So a quick introduction. Action Canada for Sexual Health and Rights is a national organization committed to advancing and upholding sexual and reproductive health and rights in Canada and globally. We are based in Ottawa on unceded and unsurrendered Algonquin territory. One of our few frontline services is a national toll-free 24-hour access line that provides information on sexual and reproductive health and referrals for pregnancy options. We also provide financial and logistical support to those who need it through our Norma Scarborough Emergency Fund. We talk to thousands of people every year. Next. While abortion access is an important focus of ours, we do not see this as a single issue, and the theory, practice, and strategy of reproductive justice are guiding principles in how we go about our work. We are very thankful for the Native Youth Sexual Health Network's leadership here in Canada, and to all visionary people and organizations like Sister Song in the US who have changed the way we understand reproductive politics and social justice. As a part of our organizational legacy, abortion care is definitely one area we have dedicated much time to push for real accessibility to all people. It is an important tool in the fight for reproductive freedom, and who has access to this service and who faces barriers unsurprisingly mirrors some of what fuels the HIV epidemic in terms of people and communities made vulnerable due to systemic oppression and discrimination. Many people here on the call I've heard have a good sense of what creates the freedom to make and act on decisions that protect and enhance health, well-being for people, their families, and their communities. And we can certainly not talk about reproductive health and rights, including abortion access, without that context. Next slide. So through the Access Line program, we get to intimately know how barriers to abortion manifest. Supporting people through their navigation of sometimes incredibly complicated scenarios really drives home the unfairness of abortion access. In Canada, access is spotty at best. Most abortion providers are in major urban centers located less than 150 kilometers from the US border. Only 1 in 6 hospitals offer abortion care, and services can be very hard to access in some places because of unnecessary strict rules and regulations. Even the rollout of the newly approved medication abortion pill, which has the potential to really address access issues, has so far played into the two-tiered system of access. We know from research and from our own frontline work that barriers to abortion disproportionately affect young people and marginalized people, especially those who are low income, people of color, Indigenous people, migrants or refugees, and those who do not speak English or French. These barriers are compounded for those living in rural and remote areas. This, of course, has profound implications on HIV-positive people's freedom to choose how and when they become parents or not, as well as how they parent the children they have, as abortion care is an important part of making choices about how we can best support the children we already have. This is in the context of the WHO recommendations that women living with HIV should access abortion, medical and surgical, like all people who need it. And so to talk about who gets to access it is really important. So on the access line, the majority of those we support live in remote or rural areas, which has implications of its own that merits more of a breakdown. For example, according to StatsCan data published in 2016, in the province of Alberta, so that province is home to about 16% of all Indigenous peoples in Canada. Approximately 45% of them live in either Calgary or Edmonton, which means 55% of them live in rural and or remote communities where there are no points of services. All points of services, there are 3 in Alberta, and all of them are situated in these 2 cities. Generally speaking, 83% of the population lives in urban areas in Alberta, and so the proportion of Indigenous people living outside of cities is much higher than the rest of the population. This means that if we don't provide abortion services outside of cities, that we impact Indigenous people much harder. This is without going into details about how service providers are in majority non-Indigenous and how we must rely on people's individual ability to support those who need to travel and to seek culturally competent services. Next slide. One consequence of having to travel long distances is that for some of us, this will mean exceeding gestational limits in some points of service because of the added complications of having to book time off, travel, pay for gas money, plane tickets, accommodations, finding childcare or elder care, etc. In some regions, too, the only information available to pregnant people seeking information on pregnancy options will come from crisis pregnancy centers, whose staff often purposefully delay people seeking services, so options dwindle. It's also the case if service providers claim conscientious objection and refuse to refer or serve people who are seeking abortion services. Later-term abortion is a longer and more complex procedure and is highly stigmatized, which further complicates accessing it. And when we send someone to seek care after 20 weeks gestation, the appointment can last up to 5 days. Of course, in most scenarios, the burden of the logistics of such an appointment falls squarely on individuals. Late-term abortion services are only offered in a handful of places in Canada, and after 23 weeks, only in the US. People have a lot of questions about late-term abortion. First off, it's a very small percentage of all abortions in Canada. And in terms of who needs to access it, of course, there are as many different stories as there are people. That said, there are some trends that are worth noting. On the access line, when we support people accessing late-term abortion, we often speak to very young people who lack appropriate power, support, and resources to realize their sexual and reproductive health and rights. And often the youth we support are youth of color and or from cash-poor families or homeless. To put this last bit in context, about 14% of young Canadians identify as LGBTQ+, according to multiple surveys of Canadian high school students. But they make up a disproportionately large, as high as 50% of the number of youth living on the streets. It's also worth mentioning that access to comprehensive sexuality education is highly uneven, not just across provinces, but across school boards and schools. We also get many calls from people who are in Canada on temporary foreign worker permits or people who are not documented. We have worked with many people who must sit through a wait period before their health insurance kicks in, finding themselves in their second trimester, or having completely missed the window of when abortion care is offered in Canada. This is compounded by the sometimes difficult relationships with employers informed by racism and anti-immigrant sentiments, which can make taking time off complicated, especially when work visas depend on their goodwill. We have worked with people who we have had to support through self-induced abortions because they saw no other way to get what they needed. We also work a lot with people who face constant emergencies like domestic violence, poverty, homelessness, problematic substance use, etc. Again, what communities are overly represented when we speak of poverty and homelessness and the impact of systemic oppression like racism or intergenerational trauma tells us of the importance of considering the implications of how we make abortion available and to whom. One example of how, in addition to barriers due to the logistics of having to travel, the need for ID being just one, I have seen firsthand how drug user stigma can further build walls. I have been in rooms with abortion providers where they discussed how they needed to make their services more difficult to access to people who use drugs because they are quote unquote tricky. They don't tell them what drugs they may be used to. They don't show up. They are difficult. Instead of finding ways to making their services more accessible, they go the other way. As for intimate partner violence, this is another space where we see the overlap between what makes people more at risk of contracting HIV and what makes people more at risk of not being able to control their reproductive lives, including deciding when to be pregnant, when and how to use birth control, if or when to access abortion. So when some people face additional barriers to accessing abortion, like it's the case in Canada right now, this only compounds the issue of access for people who are already vulnerable. And we have worked with people with whom we had to craft complex access plans that took time and care for them to be able to access abortion, knowing that because nothing is available in their communities, the traveling, when they can swing it, puts them at more risk of violence from their partners. I hope these stories have painted a picture that is compelling in terms of how we need to continue our movement building efforts to ensure that all people have the economic, social, and political power and resources to make healthy decisions about their bodies, their sexuality, and reproduction for themselves, as well as for their families and their communities. Access to abortion in the context of today's conversation is another aspect of how reproductive health and rights cannot be separated from human rights. Reproductive justice places the people and community that are more affected by, in this case, spotty and two-tiered access to abortion because of immigration laws, because of geographic location, or intergenerational trauma at the forefront of advocacy and policy efforts. Thank you very much.
Frederic, thanks so much for that presentation. A very important way to end our formal presentations today. I just want to make note of the fact that due to technical difficulties, we have run a little bit over time. So we are unfortunately going to have to shorten our question period. We will get to a couple of questions in a sec, but if you have questions beyond the timing of this, please do email them to sawatt@sfu.ca, and we'll make every effort to answer them following the webinar. So maybe what I can do is move to a couple of really provocative and interesting questions that have been posed online here. And it relates in part to the Canadian Pregnancy Planning Guidelines. So the first, this is from Natasha Davies, I believe. The first question is related to inquiring about the decision not to emphasize PrEP as a recommendation in Canada, and concern about where we're at with the 90-90-90 cascade in terms of proportion of suppressed individuals, as in South Africa, only about 23% are HIV virally suppressed, so PrEP remaining an important option. And I guess another comment in the question is that PrEP isn't considered necessary where the positive partner is a known mutually disclosed HIV serodifferent couple and is virally suppressed and worries about whether this recommendation may result in providers being less aware of the other groups where PrEP remains a really important option. So I'm going to turn to you in a sec, Mona, but I really think it is important to emphasize that when we write these guidelines that are nationwide, it really is generic recommendations, but of course in each and every situation it's very critical to have a more nuanced approach and to individualize around our knowledge with regards to the security of a partner's HIV suppression and adherence to medications, and our confidence that that partner is consistently suppressed. And in situations where the partner is less well known, certainly PrEP is used and considered in the Canadian context. But Mona, maybe I can turn to you and ask if you would like to comment on this question.
Sure, thanks, Deb. And Deb, it's good for you to begin to answer also. You're an author on the guidelines and you deal with this question in your practice all the time. But in the context of guidelines, it's important to know the purpose of the guidelines and who the audience is. So the purpose of this guideline is really around pregnancy planning and HIV and for healthcare providers to counsel individuals or couples who are engaged in HIV care. We did a thorough literature review and review of all the data related to PrEP and HIV. And in the Canadian context, the majority of people who are planning pregnancy and in preconception are engaged in care, and the HIV positive individual would be on antiretroviral therapy and fully suppressed. And in that context and in that setting, PrEP is not recommended by many countries, and that you're adding a medication that is not needed and could have side effects. So we're not recommending it. Of course, that doesn't mean that PrEP is not useful in many other settings, but that's not the goal and purpose of these specific guidelines. And we do have the special statement within the guidelines that that PrEP should definitely be considered if individuals are planning to conceive or have condomless sex, if adherence isn't confirmed and if there isn't a suppressed viral load. And in many cases, if a couple is having condomless sex or is at high risk, and one individual is starting antiretroviral therapy, and they're in the serodiscordant couple, the HIV negative partner is started on PrEP at those initial stages, such as in the partners demonstration project. So all of these were considered.
So Mona, second question, sort of related, is the question of the interval of undetectable viral loads a month apart. And that's not even the usual interval that we test people in the non-pregnant setting, and whether that's both economic and an appropriate, in the South African setting, they're not going to be able to get those kind of frequencies of viral loads. Do you want to make a comment about that as well?
Sure. Yeah, I mentioned that while I was giving the presentation. And again, what was written was, again, for the Canadian context. In Canada, it's standard when we start an individual with HIV on antiretroviral therapy, we actually see them once a month and test viral load monthly until they're suppressed. So that's common practice in Canada. But even without that, the standard before was based on the Swiss statement, which said that that there was no risk of sexual transmission of HIV if the HIV positive individual is on effective antiretroviral therapy with a suppressed viral load greater than 6 months. And that came out in 2018 with only observational studies at the time. We now have much more data to support that. And what's been written in our guideline comes from clinical practice, comes from myself and many others, seeing couples who say, well, we want to get started to use condomless sex as our method as soon as possible. So doctor, when's the soonest I can start? So from clinical data and from clinical studies, what we're recommending is 3 months, and at least you have to have 2 viral loads below the level of detection at least 1 month apart, which is consistent with sustained virologic suppression. So while we still prefer 6 months like the Swiss statement, in Canada, preferably 3 months, but if they really want to go ahead, the minimum would be a sustained viral load with a suppressed viral load with testing done at least 1 month apart. If you don't have access to antiretroviral therapy, I would say to wait at least 6 months.
Great. Thanks, Mona. Obviously, a little bit of individualizing to different settings is critical here, the principle being consistent and reliable suppression. So I'm sorry to move along here. We've run out of time. Unfortunately, I really want to thank everyone for their presentations and questions, and those that we didn't get to or others, please email them and we will respond following this webinar. We are going to have another webinar, Resiliency, Self-Efficacy, and Peer Support, that will be held on Friday, March the 9th, and look out for that one. Please join us if you're going to be in CAR on April 26th for an ancillary workshop. And really, I just want to thank everyone for your participation and thoughtful comments. And Valerie, if you would like to just wrap up for us. Thanks so much.
Thank you for joining us today. May we take all these teachings and may we learn from them and teach our learnings. Bring it full circle. Remember, those that we research are not just a statistic, and that we still face stigma, discrimination, and criminalization. But we are women first. I live with HIV, but it does not define me. I honor this journey. As life givers, we have reproductive rights and to honor traditions and ceremony. We have heard today reproductive rights and land rights. Let's learn. Our bodies are choices. And we see in research that over 40% of HIV positive women are not talking to healthcare providers. We need advocacy. We have heard the guidelines. We need to teach. Brittany's lived experience brought a strong warrior woman's voice. We need to meet the needs of mothers and listen to women's stories from the Toolkit for Mothers, Human Rights, and the Freedom of Violence. We need information to make healthy choices and to support whatever decisions we make. As we all walk on our Mother Earth, which is the very first heartbeat, which is honored by our Indigenous drums and drumming, and the first thing we hear in the womb is the beat of our own mother's heart. We have our moon time, our connection to Grandmother Moon, our most spiritual connection every month. May all our hearts beat as one. In my language of my dad, Nemotis, till we meet again. Thank you.
Thanks so much, everyone, and thank you for participating and attending. We're going to close now. Thanks so much.